Hello everyone. In this video, we shall learn about the different clinical aspects of nystagmus. But for the ease of memorizing, we shall learn it with a unique mnemonic and not in the conventional order. The mnemonic being VISION, where V stands for Visual Acuity Assessment, I for Investigations, S for Surgical Correction, I for Imaging, O for Optical Correction, and lastly N for Nystagmus Description. Nystagmus, as we know, is a rhythmic, involuntary to and fro movement of the eyes incorporating a slow phase. Coming to the first aspect of visual acuity assessment. Assessment of visual acuity is very important and can take longer time for evaluation than usual. One should look for any abnormal head posture assumed by the patient. Visual acuity assessment should follow a pattern which includes assessment of the binocular distance visual acuity, letting the patient adopt the abnormal head posture, followed by assessment by occluding one eye by fogging technique preferably. While doing this, we should keenly observe for any abnormal head posture, decrease in visual acuity, change in the direction or intensity of nystagmus. We should then assess the binocular and monocular visual acuity by keeping the patient's head in primary position, followed by a similar pattern for near visual acuity. Following this, we should know the necessary investigations for diagnosing and documentation. It is important to determine if an identifiable etiology of nystagmus is present, and thus a careful evaluation must be carried out. We should look for any foveal hypoplasia, which may be associated with aniridia or albinism, or may be an isolated anomaly. We should look for optic nerve hypoplasia and optic atrophy, which may be due to tumors or hydrocephalus, which warrants additional neuroradiological imaging, and should also look for any media opacities. So as seen, we should order for OCT, slit lamp and fundus photographs for such conditions wherever applicable. In cases where the ocular examination is normal but there is vision loss, we should get a VEP or ERG. For any retinal dysfunction, as in cases of Leber's congenital amaurosis, where we see nystagmoid movements. Coming to the next parameter of surgical correction. Abnormal head posture is one aspect related to nystagmus which is amenable to surgical correction. And in this segment, we shall learn about a few procedures performed for its correction. Abnormal head posture is due to an eccentric null point, and by surgery, we aim at bringing the peripheral null point to the primary gaze. Face turn is most commonly encountered, and a face turn of about 15 to 20 degrees. We perform an Anderson's yoke muscle recession, while in larger angles, Kestenbaum procedure involving resect on the horizontal recti or modified Anderson-Kestenbaum procedure involving unequal resect on horizontal recti can be performed. Using a similar principle, vertical recti or oblique have been operated for chin depression, elevation, or tilts. A word of caution here that before deciding on the surgical approach, we must first ascertain that the direction of null zone and thus of the abnormal head posture is consistent, as in cases of periodic alternating nystagmus. Next in line, we shall discuss about neuroimaging. So, when do we order for a neuroradiological scan? In patients complaining of oscillopsia, any recent onset nystagmus, which is asymmetric, disconjugate, and vertical. So let's see a few examples. In this video, we see a downbeating nystagmus, and on neuroimaging, we see enlarged ventricles suggestive of hydrocephalus. Downbeat nystagmus can also be seen in cases of lesions at cervicomedullary junction and drug toxicity like lithium. Here we see a seesaw nystagmus, which is typically seen in cellar or paracellar region lesions as seen here. In cases of acquired gaze-evoked nystagmus, we should look for demyelination at the brainstem and cerebellum. Apart from the ones shown here, we should never miss out to order neuroimaging for cases with upbeat nystagmus which may have lesions at the posterior fossa, periodic alternating nystagmus which may have lesions at the cerebellar nodulus, and convergence retraction nystagmus which may have lesions at the dorsal midbrain. Now coming to the most simplest mode of management, optical correction. We can prescribe over-minus lenses which stimulate accommodation and can thus dampen nystagmus by inducing convergence to some extent. Prisms have a dual role. Base-out prisms are prescribed to stimulate fusional convergence, and they can also be used to decrease abnormal head posture by placing the prisms with the apex towards the direction of preferred gaze bilaterally. Now coming to the final segment of description of a nystagmus. While observing a patient with nystagmus, we should note if the nystagmus is monocular or binocular, and if binocular, whether both the eyes are behaving similarly. The plane or direction of nystagmus in all gazes, and the extent and speed of its excursion, that is, its amplitude and frequency, whether it dampens on convergence or if the patient assumes any abnormal head posture. So after learning this, let's take a few exercises. A jerky nystagmus shows a slow drift from the visual target and a fast corrective saccade back to the target which describes its direction. So in this case, we see a binocular conjugate horizontal right beating nystagmus with a moderate amplitude and frequency. It is right beating in the right gaze and the amplitude is less in the left gaze. It is horizontal in the up and down gaze as well. Here we see a dampening on convergence, and as the null point is in the left gaze, we see that the patient assumes a right face turn. A pendular nystagmus shows a smooth back and forth oscillatory movement which is equal on both sides as seen here. In addition, it becomes right beating on right gaze and left beating on left gaze. It shows no latent component and it does not dampen on convergence. A seesaw nystagmus typically shows elevation and intorsion of one eye with a simultaneous depression and extorsion of the other eye, followed by a reversal of cycle like a seesaw. To conclude, we can use this mnemonic of vision to ensure a simplified evaluation and management of nystagmus. Thank you for your patient listening. Until next, goodbye.